Hi everyone, this is Christina Ackerman, web editor for JEMS, welcoming you to today's webcast. It's about time, addressing the crisis in communications in healthcare and EMS. Today we're going to hear a case study from Colorado Springs about the steps they took to improve emergency communications in their community. And it's my pleasure to introduce our speakers for today. Dr. Stein Bronsky is the medical director for the Colorado Springs Fire Department in AMR in El Paso County. And James Woodson, MD, is the founder and CEO of Pulsara. And with that, James, I'll turn it over to you.
Great. Thank you, Christina. So we appreciate everybody joining us today. So what we'd like to do today is really take the time to describe what we believe is really an overlooked crisis in healthcare. And then we'll talk about how we solved this problem, how we're addressing this problem. And then Dr. Bronsky will join us, and we'll be talking about how he helped really operationalize an entire region to deploy this platform. And then he'll discuss some of the results that they're experiencing. So the first thing I like to do is really kind of set the stage of what problem are we trying to solve. A lot of times people will hear about Pulsara, or they'll be looking for a solution, and they are kind of looking with blinders on. They'll start thinking about ECG transmission, or others are just pre-hospital notifications, maybe converting an oral radio report over to an electronic pre-hospital notification. There are others that are focused just on their STEMI process of care, or others just on their stroke process of care. And really what we want to do is focus the problem on a couple of things. The first one is really communication. A lot of times we take communication for granted. We don't really dig into all the different components of communication, answering some sometimes hard questions, such as the who, what, when, where, why, how, and how much. A lot of times people start trying to add more and more on, and it gets unwieldy. Other times people don't really focus on the communication channel. So we have to transmit information across a bunch of noise. And a lot of times we choose the wrong communication channel. We'll be talking today a lot about mobile technology like iPhones and Android phones and tablets, etc., and how that might be a better channel than some of the archaic technology we use. The next thing that I really want to make sure that we're focused on is teams. So we really focus on building regional systems of care and communication in regional systems of care. So what we like to do is focus on being able to touch a button, flip a switch, and instantly build a team. So a team for something like a heart attack or stroke or other time-sensitive emergency, you need to be able to manage communication and logistics, not just during the pre-hospital space, but during the intra-facility or within the facility that's taking care of the patient, and sometimes transferring the patient. And so really when you look at the unique complexities of things like time-sensitive emergencies, you can have resources scattered across an entire city or an entire region, and every single day and every single patient during that day is going to have a different team. So the question that we're really trying to focus on is, well, how do we manage these teams? So I like to start by currently asking how and pointing out how we do it now. Before we dig into how we manage something like a heart attack, I like to answer or ask some specific questions. One is, for example, when's the last time you paged somebody and that person can't be in healthcare? Most of the time, we kind of look around the room and no, we don't really use pagers anymore. How about emergently fax a grocery list to your spouse? Well, no, we don't do that either. And then another one is, how many times do we pick up a handheld radio and call our spouse and let them know that we're coming home, we're coming in? We don't do that in the rest of society, and there's a reason why we don't do it. But with that as a kind of a backdrop, let's look at how we do communication for something like a STEMI case. So we'll go ahead and have the medic on scene. They've already done a 12 lead. They've identified a STEMI. What they do from there is they typically Bluetooth or get the ECG into an old-fashioned modem. They send it up to a receiving station. And then from there, we typically distribute it one of several ways. Either it goes to a fax machine or there's a blinking computer over in the corner, or maybe there's a blast email that gets sent out, and people have to try to find the right ECG on that email. They also they can't track it because they can't use that knob thingamajigger on the monitor to get in the name. So after they get the ECG transmitted, they typically have to pick up an old-fashioned two-way radio. Sometimes they do it by phone, and they basically give an oral report to a nurse or somebody there at the hospital. And then once the hospital team starts to get mobilized, what they do is they typically send off a blast page, and so literally 10, 15 members, depending on what type of time-sensitive emergency it is, a page will go out. Then everyone has to stop what they're doing. They actually have to use their own personal cell phone and call an operator who has a list, and they're checking them off the list to see who knows what when. And then they basically patch together the rest of the communication with a hodgepodge of HIPAA-compliant, non-HIPAA-compliant messaging, tons and tons of phone calls, often where pagers are used, unit clerks, answering services, et cetera. And all this time, effort, and money we use to spend to get the ECG to the emergency department, we usually whip out our smartphone, take a picture, and text it to somebody anyway. And then what happens, if it's a transfer, you have to basically get all those same complexities we just described, but then try to get through a transfer center using all the same archaic technologies. We could go on and on by re-involving EMS into the process for that transport, but I think you get the idea of how many different archaic technologies we patch together, how many of those leverage the oral tradition, which when we say it, basically it just turns into vapor and goes away. It's not data that we can use thereafter. And so really one of the questions that we have after that is, well, is that a problem? This is kind of our reality check slide where we like to put things into perspective. It's not to minimize any of these conditions or anything like that, but I can't watch a football game without pink ribbons, can't fly Delta without pink ribbons, can't turn on the news without hearing something about the opioid epidemic. But each of these conditions, whether it's gun violence, vehicle crashes, breast cancer, the opioid epidemic, you're typically looking at 30,000 to 40,000 people a year that succumb to this disease or this tragedy. However, when we look at miscommunication and medical errors in healthcare, the numbers are pretty astounding. So estimates show anywhere from 250,000 to 400,000 people a year die from miscommunication, from medical errors. On top of that, there's another 10,000 serious medical complications every single day. And this is all because of miscommunication during transitions of care. So if we basically look at, well, why does that occur? Well, we put our teams in silos. So we give EMS, we give them modems and phones and radios, and then we end up giving the neurologist and cardiologist and our specialists, we give them pagers and phones. And then we expect the emergency department to kind of be the person that patches all these things together. And so basically we've created siloed teams, and our teams are siloed, especially when it comes to their communications, away from each other. So this really turned us a few years ago into really looking at modern platforms. How is it can we go onto any device that has connectivity and do something like Amazon that can bring together millions of buyers, millions of sellers, billions of products. With a tap, I can bring in reviews of those products. With another tap, I can bring in financial institutions, and that information is every bit as sensitive as our PHI in healthcare. Another tap, I can bring in logistics companies. So literally anywhere in the world with connectivity, I can with a couple of taps, see, evaluate, purchase, and watch my shoes delivered to my front door. Whereas in healthcare, we're patching together all of these archaic communication technologies. And so what we've built is a single version, multi-tenant communication logistics platform. So what does that mean? Instead of a highly siloed program that you see or system that you see on the left, it's a single version. There's just one version of Pulsara. So the other component of that is multi-tenant. So what that means is I can add a team member with a tap of a button to surround a patient to stop a time-sensitive emergency. And so that is what Pulsara has built. A couple of key components to that is no longer are we kind of quarantined off by EMS agency or by hospital. We can cross those boundaries, so we can bring multiple EMS entities and multiple hospitals together on the same page to assist this patient. So the next thing is really this is one communication standard. We are there to help operationalize best practice standards to really simplify and standardize the protocols for time-sensitive emergencies, really regardless of time-sensitive emergency and regardless of method of arrival. And that's because we truly unite the pre-hospital, intra-facility, and inter-facility teams. So with that, we're gonna pause for just a second and watch a 3-minute video that's kind of a demo video of the Pulsara STEMI solution in action. If we could go ahead and roll that video.
A medic quickly starts a case by tapping New on the home screen. Then they tap on the STEMI module, select their destination facility, and enter their at-patient and scene departure times. Distance and ETA are auto-calculated using GPS. The medic can then enter the patient name and a few quick yet vital pieces of information. Adding a contact makes it possible to call a witness or family member directly from within the app, even after the case is complete. Save 1,000 words with a tap by adding a picture to the case. Images aren't limited to ECGs. A quick snap of a handwritten medication list or a driver's license is shared with the whole team in seconds. With another tap, the hospital immediately receives an alert. EMS is notified when the hospital acknowledges the new inbound case. The hospital is then able to see critical information about the patient, including the ECG. All team members, including EMS, can send HIPAA-compliant messages using customizable templates. At this time, if the hospital wishes to activate their STEMI system, they can select the on-call ED physician and cardiologist and tap Activate. All on-call team members and all assigned physicians are simultaneously notified. If your facility is like others, that trusted on-call list is constantly being updated, no problem. It is simple to reassign another physician to the case. When the cath lab is ready to receive the patient, they can notify all team members with a simple tap. Anybody can quickly add a message for the entire team with a couple of taps. The Stop STEMI module is divided up into logical window panes. The next 2 panes are for the emergency department and the cath lab. The ED can instantly notify the team when the patient has arrived by entering the door time. For accountability and transparency, all team members can see the uploaded images and who is on call. In the Teams section, members can see a summary of every person associated with the case, alerts they have acknowledged, and with a single tap, they can call them directly from within the app. Key metrics like door in, door out time, and activation to cath lab ready are automatically captured. In addition, our bar timers provide visual clues to each department regarding where they are in their current case with respect to their facility averages and facility benchmarks. And, of course, the ever-present universal clock keeps everybody synced. To stop a case, simply tap Stop STEMI. Now you can select the stop indication, and everybody, including EMS, is immediately notified. Now everybody can see a summary of the patient outcome.
Okay, it looks like the video has completed here, so I'd like to dig back in and also let everyone know that the demo videos of all of our different solutions within the platform are available at pulsara.com. So the first thing I really want to point out from here is what we're not, which is a magic bullet. One of the things that used to frustrate me when I was on the receiving side of these is it made it sound like this was going to solve all of your problems that you have out there. And really one of the things that I'd like to highlight is we love to be the partners of these organizations. And this is what we'll get into talking with Dr. Bronsky here in a minute, because you really need to surround this platform with amazing processes, and this is really a tool and a new way of doing the job. What it does do is, instead of trying to link together a bunch of silos with chains where we're doing kind of one-to-one communication or one-to-few, we've really built a neural network. So instead of sitting in STEMI meetings and stroke meetings, et cetera, what we like to do is basically in real time give the tools to identify when there's a breakdown in communication and the tools available to solve that problem in real time. So in essence, what we've built is a neural network or a shared consciousness where the strength of the system is truly greater than the sum of its parts. And so the results that we get, you can also find these results on our website at pulsara.com. You can see typically we're reducing everywhere we go STEMI and stroke treatment times between 10 and 46%. I'll let you guys dig into the studies there. We have some other studies that will be released here next week at the International Stroke Conference. So what we do now is we focus on end-to-end care for STEMI and stroke. We also can replace the radio report for all EMS patients, for all general patients. And so one of the other things that I'd like to highlight, and Dr. Bronsky will get into this a little bit, is when you start to operationalize this in a system, Dr. Bronsky will show one example where an entire region started all at one time. But there's also the ability to spin this up where it's led by EMS, other areas where it's led by the hospital end. We make all pre-hospital communication for free. So that radio report that's traditionally done, we're replacing that with an electronic pre-hospital notification, and that's done at no charge. Currently, that's at no. We've always had it at no charge to EMS, but we're also making that at no charge to the hospital. What we're trying to do is open up teams and regional systems of care. And so by giving this piece of the platform away for free, it allows us to go in and show how we can solve a much larger problem for the entire system, specifically all the complexities at the hospital level. We will be building out other time-sensitive emergency modules like trauma and sepsis, cardiac arrest, and others. We'll also be bringing more video components into this platform and moving towards more passive data collection and integration down the road. So the final thing I like to focus on is really the purpose of what we do. Our focus is to improve the lives of patients and caregivers through innovative communication. We feel very strongly here at Pulsara that if we focus on the providers, on the caregivers, that's the way that we can actually leverage technology where it's helpful to us as practicing clinicians and not just something that looks good on paper. And by focusing on these workflows of the clinicians, really truly uniting them, we believe that's the best path forward to using technology to improving patient care. So with that, I'd like to turn it over to Dr. Bronsky.